Ciao. The next speaker will be Luiz Albernaz. Hopefully I speak it correctly. Treatment of foot varicose veins, an observational study. Please.
Good morning. Initially, I'd like to congratulate the organizers on this memorable and very educational Congress. And thank especially Dr. Willie Shi, whose work is highly appreciated in Brazil, for his incentive and support. My name is Luiz Fernando Albernaz, and I have no disclosures. We decided to study foot varicose veins because there are few relates in literature. Our objectives are to review and analyze consecutive patients who underwent foot varicose veins treatment. From January 1st, 2013 to January 1st, 2014, consecutive patients who underwent phlebectomy for symptomatic varicose veins treatment were analyzed. Ambulatory phlebectomy of the foot was performed as part of limb varicose vein treatment, along with adjunctive therapy like intravenous laser therapy, 14-17 nanometers, and polydocanal 3% foam whenever treatment of below knee saphenous vein was necessary. In the post-procedure period, class 1 or 2 compassionate stockings were applied. Analgesic and or non-inflammatory, non-steroidal inflammatory, anti-inflammatory was prescribed as needed. All patients were submitted to the venous duplex ultrasound at every follow-up visit. It was scheduled 7, 30, and 90-day follow-up. We decided to include clinical etiology, anatomy, and classification to categorize our sample, and VCSS in the pre- and post-treatment period. The results were compared and submitted to the student t-test analysis. Our procedure complication rates were compared with literature using chi-square and Yates correction. A total of 64 feet with symptomatic varicose veins underwent intervention. In the sample, 46 patients, 34 female, were included. The age ranged from 28 to 74 years with an average of 51. Based on CAP classification, C2 is the most common, followed by C3 and C4. Only 3 cases were included in C5 and C6. The average VCSS was 5.37 before and 1.86 after. We found statistical significance at this point. Regarding outcome complications, around 73% had no complications at a 3 months follow-up. Around 15% had edema, where mostly of them were transient. Only 1 case lasted more 90 days. We found also transient paresthesia, transient hyperpigmentation, and as less frequent complication, infection and lymphatic fistula. The results of 3 authors were depicted in this table and compared with ours using chi-square and Yates correction. I have some words about it. Anesthesia-related complication, as described by the author, was due to the intravenous injection, considering the thin subcutaneous layer at this site. Blisters and necrosis, it was due to the too tight bandage and the foot skin management. We didn't find this kind of results in our series. Hyperpigmentation, it's a common complication and fortunately is transient. Regarding hematoma and melting, we have a strong belief about the importance of ligature of every vessel's edges. Small batches we do cauterization, bipolar electrocautery. These aesthesias are not an infrequent complications, and it's caused by the relation between vessels and sensitive nerves at the site. Mostly of them are transient. Analyzing DVT, the absence of results in all series is very important. It can mean that foot procedures might not be so risky, so it encourages to do more practice in this site. We found statistical significance in edema. We believe it was due because we used to do sclerotherapy associated with phlebectomies at this site. In our series, foot varicose vein intervention was relatively safe and effective. Our treatment complications were similar to the literature. CAP and VCSS has proven to be a powerful tool to measure and evaluate foot varicose vein treatment outcome. We have some pictures for our appreciation. The left one was shot in the pre-op period, and the right one in the 3 months follow-up. Thank you for your attention. I would to invite you to go to São Paulo, March 2015, to the International Meeting of Aesthetic Flebology. Take a look on Facebook. Thank you again.
Thank you very much, Dr. Albernaz. Are there questions from the auditorium? Dr. Follini?
Yes, probably I didn't catch it. You said you made this kind of treatment at the same time of the treatment of the saphenous vein, or you make it separately?
Yes, we do in the same time. We treat varicose veins of the limb and the foot.
Because usually, at least in my practice, I prefer to first to perform the treatment of the saphenous trunk, then wait, because most of the time, what you have on the foot initially will be much smaller after a few times, and the treatment will be much easier. And even complication, edema that you mentioned, will be minor problem if you do just a few months after.
Yes, I appreciate your observation. We have a private clinic in Brazil, and persons were very demanding about aesthetical results. And we have this practice to do sclerotherapy in the one sitting, treatment of varicose veins of the limb and the foot.
Mm-hmm. Anyway, I can tell you, I also have a private practice, and Italian women also are very demanding.
Yes.
Hello, sir. Thank you. My name is Jeff Sabatino. I'm from Milwaukee, Wisconsin. I have no disclosures. As you were injecting veins around the foot, did you try to keep the sclerosant out of the deeper level circulation in the foot, and using visualization with ultrasound? And then what volumes did you use as you injected?
Excuse me, if I understand, you asking me if I use low quantities of sclerotherapy?
What volumes were you injecting, and were you...
Oh, yes. We used to inject dextrose 75%, and we have no limits to sclerotherapy, to do sclerotherapy.
Thank you. Thank you.
Hi, Oliplos Albuquerque. A generic question. The authors that you cited, as well as your own study, showed no DVT. Has anyone here ever seen a DVT of the foot? I have never heard of it.
Yeah, I did.
You have?
I never saw foot thrombosis, but I reading about it. Labropoulos had described a case of thrombosis, and he suggests us to do ultrasound in foot in every physical examination in our office, and it's a kind of a simple thing to do.
Thank you.
I did see a foot DVT, but not after sclerotherapy or after intervention, after climbing. So this is possible.
And you treated that?
As a normal DVT.
Okay, thank you.
So thank you very much, Dr. Allen.
Thank you.
So we will be moving on to our last presentation of the day. Dr. Stefano.